Hello, I'm Dr. Salma El-Houchi. I'm a professor of pediatrics and neonatology in Cairo University, and my lecture today is about how to best feed our preterm babies. These are our premises: Abu Rish Hospital, the Japanese one, the red one, the CSPM, and the white in El Munira. And you will all most welcome to come and train in our hospital. The target of our lecture today is that we need to know our nutrition objectives, plan for a possible transition from TPN to enteral feeding, plan enteral feeding, and define NEC, necrotizing enterocolitis, something that we are all scared of. These are some examples of cases that you will be facing in your NICU. For example, a day 1 preterm baby, 30 weeks gestation, 1.2 kilograms. He has RDS and toxurfactant as now stable on CPAP. So what type of IV fluids do you give? What's the volume? Do we start trophic feeding? What's the amount and ideal type of trophic feeding? You start with the dextrose 10%, that is in case of TPN being not available, at an 80 to 100 ml per kg per day. And yes, of course, start trophic feeding as early as possible with 1 ml expressed breast milk. That is the ideal for this baby. A 1.8 kilogram baby, 30 weeks gestation, the baby's feeding 10 cc of premature formula. And then each type of formula had its own caloric content. Sometimes you need to memorize some of the formula's caloric content, but most of the time you can just see it on the box of the milk. So this type of formula has an 81 kilocalorie per 100 ml, and he's taking 10 cc's every 3 hours by a nasogastric tube on day 6 of life. So how do you calculate the calorie intake from these enteral feeds? And if the baby is tolerating feeding well, how do you order the feeding on the very next day? And how do you monitor the baby's tolerance and advanced? So to calculate the feeding, you have an 80 ml feeds. You multiply the 80 ml by 0.81 to know the total caloric intake of this baby. And then you divide by his body weight. So he's taking a total of 64 kilocalorie per kg. 64 kilocalorie total, and then if you divide by his body weight, he's taking a 36 kilocalorie per kg. On day 7, you need to increase his feeding by 20 to 30 ml. So what you do is you add 20 to 30 ml per kg to the 80 ml he was previously taking. So multiply 20 or 30 by 1.8, and then you see what's the total amount that he's gonna take. So he's gonna take 116 to 134 ml per day. You divide them every 3 hours to see what's the amount he's gonna take every 3 hours. And you need to monitor vomiting, residuals, stools, or abdominal distension. Those are parameters increasing feeding. This is a day 1 preterm baby, 32 weeks gestation. He's 1.2 kilos. He has RDS and toxurfactant. He's also stable like the baby in the first case. What's the TPN prescription, volume and content, and do we start trophic feeding and why? TPN, we need to calculate the total volume, that is 80 to 100 ml per kg. The protein should be 3 grams per kg per day. Lipids, you start on 2 grams per kg per day, and you calculate your GIR, the glucose infusion rate, at the rate of 4.4 to 6 ml per kg per minute. And we will go into details more of the TPN prescription later in this lecture. And yes, we start trophic feeding. The baby is stable. This helps gut priming, activates the enzyme, and reduces the time to reach full feeds. Another question, you're writing the IV fluid order of a day 3 preterm baby, 31 weeks gestation. What's the volume of the IV fluids, and how do you monitor the volume? Is it a constant volume? You see a range. Like for example, 20 to 140 ml per kg per day. So why is that a range? Because you have to look at his weight, his urine output, if there are other losses. If his sodium is high, maybe he's dehydrated, so he needs more fluids. By examination, does he look dehydrated. Is he on phototherapy? And we all know that phototherapy increases the fluid loss in the baby. Last one, a 32-week baby has been admitted to the NICU since birth and he's stable on CPAP. You are writing the order for enteral feeding on day 3 of life of this baby who weighs 1.3 kilos. The enteral feeds of the previous day were 3 ml of EBM, that is expressed breast milk, every 3 hours. What's the ideal rate of increase of trophic feeds for this baby? How do you increase the trophic feeding? What parameters do you look at when deciding if you want to increase? And under what conditions do you consider stopping enteral feeds? So once you reach a 24 ml per kg per day, this is when you stop the trophic feeding and you start to increase at a rate of 10 to 20 ml per kg per day, advancing feeds, and you always look at abdominal circumference, residuals, color of stools, the general condition of the baby. Is he vitally stable? Does his color look normal? Is he in sepsis? So when do you stop? If you suspect definitely NEC, if there is intestinal obstruction, if you don't hear any bowel sounds, if there is unstable hypotension, or you're using high vasopressors, or the baby is in severe sepsis. The past 50 years have seen major advances in the clinical care of the preterm infants. To nourish is to flourish. So this is what happens at birth. The feeding of the preterm infant is a substitute for the placental nutrient supply. You see, when you're cutting the cord, you're just stopping all the nutrient supply to the baby. He has been taking proteins, carbohydrates, lipids, and vitamins and minerals in a very nice and very continuous form, and then you cut the cord and all these nutrients are suddenly stopped. Do we know how much does the fetus need? This is Ziegler. He's a very well-known professor of nutrition, and he published in 1976 a very important paper analyzing chemically the human fetuses for gestational ages starting 24 throughout 40 weeks gestation, and that's how we know the daily increments of body components, and that's how we calculated them. What's the adequate growth velocity? You want this baby to grow at an 18 gram per kg per day, and you want his head circumference to increase almost 0.9 centimeter per week to ensure an adequate outcome, and you want to save his brains and not his life. How do we assess this growth velocity? We have this Fenton growth curve. It's not really clear, but what you show on the x-axis is the gestational age. What you see on the y-axis is the weight, the head circumference, and the length. And this is when you plot, this is the Fenton growth curves. You plot the baby and you see what was the baby supposed to grow during his intrauterine life, and then you know what should happen in your NICU. So what are the stages of TPN? At the first 5 to 7 days, we start with an adaptation and stabilization stage, and we don't expect a weight gain. And then the stable growth occurs. What are the components of the TPN? We have the proteins, and now we start on a high protein that is 2.5 to 4 grams. So the protein is in grams, not in milligrams, grams per kg per day. And you start in the very first 24 hours of life, and this is very, very important. We don't wait for anything to start the TPN. Just start immediately once the baby is born. What are we scared of? We're scared of the azotemia, acidosis, amino acid imbalance. These things are already monitored anyways. So you monitor your liver functions, BUN and pH, and you start with proteins. So what kind of calorie does protein give you? 1 gram of protein provides 4 kilocalorie for the baby. What about fats? You start with 1 to 2 grams per kg per day, up to 3 to 3.5. It's an energy source that is very beneficial because it has low osmolarity and high energy content. So each gram of fats gives the baby 9 kilocalories. So each gram of protein, as we said before, gives a 4 kilocalorie, whereas the fats gives 9 kilocalorie. What's the problem of the fats? It may displace bilirubin from albumin, alter oxygen diffusion, some problem with platelet dysfunction. We always can monitor the serum triglycerides. Carbohydrates are calculated by the GIR, so when you're writing the prescription for the TPN, you send the target GIR depending on your blood glucose level in the previous day, ranging from 4 to 8 milligram per kg per minute up to 12 milligram per kg per minute. And then make sure that if you're using more than 12, you're not using a peripheral line. So the maximum you can use in a peripheral line is a 12. The caloric value is 3.4 kilocalorie per gram. It has a major contribution to osmolarity. The problem is that you should not depend on it because this increases lipogenesis and can cause complications like steatosis in the liver. You add sodium, potassium, chloride, magnesium acetate. Some of them you just prescribe them according to the sodium that you are writing. The sodium is 2 to 3 milliequivalent per kg. The potassium in 1 to 2 milliequivalent per kg. Chloride, magnesium, and acetate are usually put in the total parenteral nutrition. You start also calcium at 60 milligram per kg per day if the baby is a preterm. In a term baby, you start at 50 milligram per kg per day. Phosphorus is also added to the TPN. What are micronutrients? Micronutrients are chemical elements that are needed only in small amounts, and they include vitamins and minerals. So what happens in the TPN is that they have a concentration, like the two examples I have over here, like the multitrace neonatal or the Adamel. Actually, these were a few years ago. I don't know if there are newer things. They're just a combination of micronutrients put together and added to the TPN. Ultra micronutrients that are needed in very, very small amounts, like the copper, molybdenum, selenium, and they have different benefits. The intravenous vitamins, like the A, D, E, K, vitamin D, and the B complexes. How do we monitor? We monitor electrolytes daily, triglycerides especially considered during initiation, liver functions after 14 days to avoid cholestasis. What's the current situation? This is a French survey published in 2015, and they found that most of the babies born between 30 and 33 weeks are not following the international guidelines. They're having insufficient parenteral nutrition, and actually clinicians, they lack the adequate education and training for parenteral nutrition prescription. Another study published in Neonatology 2018, it shows that nutritional intake during the first week of life did not reach the current recommendation, and it aggressively supports the early nutrition management of extremely preterm infants. What's our status? This is our unit before innovation with the incubators really close to each other, and this is the new one being opened a few years ago. In developing countries, we don't have access to sophisticated technology. You know how precious is the incubator in Egypt to find one and to keep the baby in. How do we decrease the duration of stay? We have macronutrients and micronutrients. The macronutrients are proteins, lipids, carbohydrates, and we need a protein energy ratio of 3 to 3.6. Micronutrients, as mentioned before, they include minerals, vitamins, and trace elements. Let us always remember that enteral feeding remains the safest and the most accurate method for both macro and micronutrients. So whatever we do with the IV alimentation, it's not like the enteral feeding. So why don't we start enteral feeding directly in preterms? There is metabolic and GIT immaturity. This baby has minimal nutrient stores. He is mechanically ventilated. He needs oxygen. He has some surgical problems. What do? We start with the red line with the enteral feeding starting, and then the blue line is the parenteral nutrition starting, both at the same time, and then by increasing the enteral feeding we decrease the parenteral nutrition so that we end up by a total caloric intake that is taken through the enteral feeding. Phases of enteral nutrition, we start with the TPN and gut priming, that is the trophic feeding, and then there is a transition feeding, enteral phased in, parenteral phased out, enter, and then the post discharge. Does have problem including vascular catheterization, sepsis, and I need to be keen to stop it as early as possible. As soon as I reach 120 ml per kg per day or 100 kilocalorie, this is when you stop the parenteral nutrition and you depend only on the enteral feeding. This should be reached as early as possible. Try to reach it within 2 weeks. The type of milk used, breast milk is the best. Fortification is not available, but you have to know something about it, and the premature formula. Whatever we say about the breastfeeding, we cannot just explain in 1, 2, or 3 hours. And these are the different civilizations and different paintings showing how, since the pharaohs, probably they knew how important is the breastfeeding, and they put it in different paintings and statues explaining how important is the breastfeeding. So what's the type of milks that we have? The premature formula has 68 kilocalorie per 100 ml, 2.7 grams per 100 ml of proteins. Donor human milk is not available in our country. The preterm formula has a high caloric content, 74, sometimes up to 81. Human milk fortification is that when you add certain powder to increase the caloric content and the proteins to the breast milk. It's a powder usually of bovine milk based or human milk based, actually till now not available in Egypt. Mature formula usually contains proteins, carbohydrates and fats, vitamins and minerals. Elemental formula that is used a lot nowadays. There is limited research on semi-elemental formula. Some of the doctors want to start with elemental formula in patients suffering from NEC. Hence, the research did not recommend starting with elemental formula after NEC. How to proceed with enteral feeding. This is a Cochrane review saying that early feeding versus early trophic feeding versus enteral fasting for very premature infants does not actually increase the incidence of NEC. What is trophic feeding? This is early initiation starting at 0.5 to 1 ml and try to start at day 1 as much as possible. Whatever you're scared of, asphyxia, respiratory distress, glucose disturbances are not contraindications for trophic feeding. Trophic feeding is just 1 ml every 6 hours and then increasing to 2 with 1 ml every 3 hours. This is a very small amount that has no problem at all. When and why to start enteral feeding? To reduce major complications, start with the early enteral feeding. Help the gut to get ready. And this is the picture of the intestinal villi showing how it gets thickened. It starts to increase, to secrete the enzymes, and helps maturation of the cells to be ready for the actual feeding. We advance. We advance at the rate of 15 to 20 ml per kg per day. This is a nice graph provided by Dr. Iman Iskandar showing the trophic feeding time that takes 0 to 5 days. You start to advance at 10 cc per kg per day. You can fortify at this stage and then you stop the IV fluids or the parenteral nutrition and you maintain till you gain weight. That should happen. You should reach the maximum feeding volume as per this graph, like at the age of 20 days, for examples. Don't delay more than this. Feeding intolerance is assessed by assessing the abdominal girth. If it increases, usually measure it before the feeding, not after. Check if there is gastric residual, check if there is vomiting, stool consistency, and don't depend on a single item to stop the feeding of the baby. Always look for other items. Avoid getting out gastric residuals with a very large syringe, because this definitely will provide a lot of gastric juice and will make you think this baby needs to stay without feeding, and this is not the case. So refeeding gastric residuals in extremely premature infant is recommended because this baby has done some effort to digest and to secrete enzymes, so giving it back to him might help him in digestion. What are we scared of? We're scared of the NEC, the most life-threatening problem occurring at the 2nd to 3rd week of life. The problem is mucosal and transmucosal necrosis, affects the distal part of the ileum. NEC is a systemic disease with GIT and systemic manifestations, and it has 4 stages: suspected, definite, that is mild or moderate, and then the advanced stage with the critically ill with DIC or with pneumoperitoneum. How do you manage NEC? The problem is that there is no definite treatment. It's mainly supportive. You stop the feeding, you do some nasogastric compression, you shift to IV fluids, and you have a careful attention to the respiratory stated coagulation profile and acid-base disturbance, because you're scared that the baby has systemic complications. You withdraw blood for culture, and then you start antibiotics for both gram-positive and gram-negative, and of course anaerobic organisms. You remove the umbilical catheter, you replace with intravascular fluid, and you need close monitoring and isolation. A surgeon should be consulted, and he has all the options to, depending on what he prefers, whether it's a laparotomy or a drainage. How do we decrease the NEC? So what decreases the NEC? Antenatal steroids. Definitely breast milk decreases the incidence of NEC, so always try to have some breast milk pumped and give it to the baby. Standardized feeding regimen. This is a very important thing. Standardized feeding regimen is that we all agree in the unit to use the same feeding regimen. So we start trophic feeding for 2 to 3 days. We start to increase at 10 to 20 ml per kg per day, and then when do we stop the IV fluids? So what is the importance of standardizing the feeding regimen is that when each one rounds and increases the feeding with his own pace or with his own beliefs, this is when NEC happens. So sometimes when you round, you found the baby staying NPO for 2 days, and then one of the clinician rounds and says, okay, why is he on NPO? Let's start with 5 ml. And then another one comes, no, the baby looks fine, and the nurse decides his suckling is getting better, so I will give him 20 ml. So if you look back in the sheets, you find the baby not going in a proper, let's say, definitive way of feeding, or not following a certain protocol. He's just feeding whatever is there, or whatever the clinician in charge is saying. So please have like a standardized feeding protocol in your NICU and follow it all. Do probiotics help? Not proved. Lactoferrin and arginine may have potential effect to reduce the risk, but this still needs randomized control trials. This is Hippocrates. He said, let food be thy medicine shall be thy food. This means that most of the medicine is in the food, and all diseases, they begin in the gut. So treat the gut, you treat the disease. And thank you.